point, we're going to roll into the didactic component, and I'll do that again after we now said hello to everybody. Again, it's great to have you all here. And so I'd like to introduce Theresa Roelke. She is also a gerontological nurse practitioner. We're so excited to have her as one of our faculty members. She's a geriatric nurse practitioner, as I said, for the Maine Medical Center, where she manages the low-dose CT lung cancer screening program. Her role is to offer low-dose CT screening to eligible patients, conduct shared decision-making conversations, provide tobacco treatment counseling, manage imaging findings, conduct follow-up screening, and provide outreach to patients and providers. Additionally, she supports research for the Maine Medical Center for Outcomes Research and Evaluation Corps and the Maine Lung Cancer Coalition, whose purpose is to educate the public and clinicians about lung cancer prevention and screening, and to evaluate innovative community-based strategies to support lung cancer screening across Maine. Theresa also serves on the Maine Health Lung Screening Task Force and the American Cancer Society Lung Cancer Roundtable. Today, she's going to be presenting Lung Screening 101, implementing a lung screening program. So Theresa, I'm going to turn it over to you, and thank you so much for being our presenter today for our didactic.
Thanks for having me. So I'd like to talk a little bit about how to implement a lung screening program. So if you move to the next slide, can you move to the next slide? Thank you. So basically all major medical organizations recommend annual low-dose CT screening for people at high risk for developing lung cancer due to significant smoking history. There are some variations regarding specific recommendations, but the organizations are consistent in terms of recommending populations that were enrolled in the National Lung Screening Trial, which was completed in 2010. So just below this, you see that there is the eligibility criteria, which most of us are probably pretty familiar with, ages 55 to 74, having a 30-pack year history of tobacco use, and the person must be a current smoker or quit within the last 15 years. Next slide, please. So the ACCP and the ATS have issued policy statements on the implication of or implementing of lung screening. And this is really meant to ensure that the benefits of lung screening outweigh the risks. There are 7 recommendations, core domains for recommendations for lung screening. And what I decided to do is to, if you can move to the next slide, is to build a chart so that people can refer back to this. So the next 2 slides are actually charts that list the 7 domains on the left, and then go across, and you can look at the recommendations, quality metrics, and ways to implement. So I don't have time to speak on all of these, so they'll be here for reference at a later point for people. But what I will do is just kind of talk about 2 of them to start. So if you look at the top one, who to screen and timing, that's the domain on the top left. Recommendations are that a program collects data on all patients regarding lung cancer risk. Quality metrics are measured that the program has policy defining the eligibility of patients or who's eligible, and that insurance companies mandate the recommendations. Implementation for screening, educate referring providers on who's eligible. So our reminders can be created to timing. To have a program coordinator to provide oversight, and also to give feedback to providers if providers referring patients aren't eligible. To the next one, how is CT performed? Actually, can you just go back one? Sorry. How CT is performed. There's recommendations for that. There's recommendations for structured reporting. I'm going to talk a little bit about lung management, lung nodule management, which is recommendations are that we have experts who are people who are experts in managing nodules and cancer. It's important to have a lung nodule algorithm in place to nodule evaluation. And it's important to be able to communicate with providers and patients in terms of how these nodules are. Data collection is also important in order to track findings and, again, manage the nodules. The quality metrics are that there are designated clinicians such as radiologists, pulmonologists, thoracic surgeons. These are people who are experts in managing nodules, and so they're important to have on board. And the screening program should also have the ability to report a number of baseline scans, number of annuals, number of biopsies, the type of biopsies, number of cancers, diagnosis, etc. And so implementation for lung nodule management, something that's really important is regular meetings of a steering committee, and it should be a robust steering committee. This is actually really important for lung screening programs in general. A similar board in place to evaluate high-risk nodules, and the use of a nodule algorithm, which I mentioned earlier, and we use LungRads, and that supports our management of the nodules. And then also it's really, really important to have clearly defined responsibilities between providers and the screening program so that people know, what their responsibilities are. We don't end up with redundant orders and such. It's important to have a screening coordinator to oversee nodule evaluation, and a registry can be used to track nodule evaluation and management. Next screen, next slide, please. Other domains here, I won't get into these in detail, but tobacco therapy is another domain, patient-provider ed, data management and collection. So these are all very important parts of a lung screening program. Next slide, please. So one of the decisions that has to be made prior to the program development is what kind of program do you want to have? Do you want to have it decentralized, centralized, or a hybrid, which could be kind of a mixture of the two or a blending of the two? In a decentralized program, the PCP will conduct the shared decision-making consult, will order the scans, and manage the findings of the scan and connect with patients. And the radiology department typically will conduct the imaging and interpret findings. In a centralized program, all of the aspects of the screening program are managed under one roof, under a single program, and providers and patients are kept informed of results, etc. And then in a hybrid program, there's some centralized processes, and then there are other aspects that are decentralized and are deferred to the primary care provider. In looking at some of these programs across the country, there's a blending of all of these. It's amazing at how many variations there are out there as far as program structure. Next slide, please. So the common question, I think, for all screening programs is, who will manage all the various aspects of the screening program? And if you look down below, I've got 12 aspects, and there's a lot to screening. Who will determine what patients are eligible? Who's going to conduct a shared decision-making consult? And then who will deliver tobacco therapy? Will it be a helpline? Will it be social workers embedded in a screening program? So there will be a PCP who conducts tobacco therapy. And then, who shares results with the patient and the primary care provider who's referring the patient? How do we manage abnormal scans and keep people informed? And how do we continue to provide outreach to patients so that we keep them engaged with their annual scanning? And then there's this whole element of data tracking. Would it be paper and pen? There are some programs that may still use that technique, Excel spreadsheets, Access database, or there could be the use of more formal data tracking software such as Epic Gradient or LungView. There's a bunch of them out there. And then once you have the tracking in place, who's going to enter the data and how is it going to be submitted to registry? And what about incidental findings that are so common on this scan, such as coronary artery calcifications, emphysema? Those are found in 50 to 60% of the scans. Aortic aneurysms can often be found. So again, how do we keep PCPs informed in terms of management? And then RADS 4 findings, and RADS 3 and 4 really, if you're using a multidisciplinary team weekly, that would be important in order to present cases to the team in order to think about or consider what the plan might be. And then community outreach is vital. So programs across the country, if you look at the next slide, they continue to face low volume, low reimbursement. Management of suspicious findings is always a challenge. Data management is also can be tricky, and support from those in leadership to ensure that there are adequate resources that are available and there's support to meet the growing needs of a lung screening program. Next slide, please. Next slide, please. So must-have, this is sort of a recap. Support from leadership and a steering committee is really important and commonly found in very successful programs to set high-level program structure and to garner the support for the program. Community outreach to patients, to clinicians, including ancillary staff is very important. The program should be patient-centered as well as tobacco therapy if the program can manage it to meet the needs of the individual patient. And data tracking software in place from the start of a program, I can't emphasize how important that is. And again, redundancy, but adequate staffing, support from radiology, administrative support, because basically as the program value increases, so should the staffing. And thanks for your attention.
Thank you so much, Theresa. That was awesome. It was great information, a great high-level overview, a great way to kind of kick off the ECHO and kind of remembering all these components as we go through these ECHO sessions together. Thank you so much. So I'd like to open up just for a second.